something that, you would see the doctor for. And things may have changed a bit over the years in terms of the treatment paradigm, but the aim of treatment remains the same. So improve quality of life, symptom and inflammation control, preserve function and social participation as much as possible, or even normalize it if you can, and prevent progression of structural damage as well. And so, taking into account all these things, of course, we always want to balance things out with things like cost, side effects, because at the end of the day, you're not just the disease, you are a person, and that's what the doctors want to do, take into account everything, including the concerns that you may have about medications and everything else. The treatment of AS remains what we call a multimodal, multidisciplinary treatment, meaning you don't just take medicines, you don't just do physiotherapy, it's often a combination of quite a fair bit of things. It is multidisciplinary because we need our allied health colleagues, the pharmacists, the physiotherapists, and even our patient partners and charity partners to help with this. Okay. In severe cases, we may have to consider surgery. So like cauda equina, the compression of the nerves that we mentioned earlier on, or fractures, may be instances where we engage our colleagues from the surgical department to help with the management of our patients with ankylosing spondylitis. And so in terms of deciding how and what to use to treat someone with AS, it is important to know what the disease activity is. Whoops, okay, a bit of a glitch, sorry about that. Okay, and so what we usually look at would be certain parameters, like certain symptoms, what we call the Basti index. And so we would be looking for symptoms like fatigue, whether there's been pain, how bad has the pain been or the swelling, have you had any discomfort or tender areas, have you had any morning stiffness, and if you have, how bad is it, how long does it take for things to settle down? Okay. The BASTA is something that the patients can answer themselves, and it's fairly, it's a good indicator because patients know their symptoms better than the doctors do. And so my video is a bit glitchy today. I apologize for that. Let me just screen back. Okay. And so the next index would be that of what we call the ASTAS, which is a parameter which takes some of the things that were asked in the BASTI, but it also takes into account the inflammation markers that your rheumatologists or your doctors would run during your clinic visits, as the ASTAS is a reflection of the inflammation that you're experiencing as a result of your ankylosing spondylitis. And so, keeping track of symptoms can sometimes be hard. Life can be very busy for patients, or caregivers. And so, and calculations are not straightforward. It's not just adding on numbers. Nowadays, there's actually a lot of apps available in the various app stores. So ASAS, which is the spondyloarthritis Axial Spondyloarthritis Society, basically has an application with the calculators and even some of the criterias. Novartis, as we mentioned earlier on, has an app as well, and there's many other applications available online to track the various types of arthritis, not just ankylosing spondylitis. Okay, in the clinic, the doctors will also be looking at a bit more objective measures, meaning in terms of how your range of movement has been affected by AS. And so there are certain measurements that we do in terms of the range of movement of the spine, whether you can bend sideways, bend forward, whether, you're a bit more hunched, and that's why, we measure the distance from the ear to the wall. And so when we're looking at disease activity markers, the question then is, okay, so how do I use that numbers? Is there a certain target that I need to achieve to say that things are really good, because there's no point calculating numbers and not doing anything about them. Okay, and so the ASTA score that we mentioned earlier on, the later part, has a few tiers where it says, well, is inactive disease or very well controlled disease in remission, or very high disease activity, indicating a lot of inflammation. And we also have certain cutoffs to say, yeah, significant improvement, not really that good, or, deterioration. And generally, we do have targets that we do want to achieve as much as possible in active disease, but if not, we do want to reach low disease activity. And so how do we reach these targets? There are guidelines that are considered by your doctors. Generally, the first line treatment would always be the NSAIDs or the non-steroidals, and we use these non-steroidals or the painkillers, so to speak, to reduce inflammation and manage your pain. If we don't see much of an improvement within 4 weeks, the recommendation, of course, is to swap to biologics if there's involvement of the spine. And currently, the common practice is still a class of biologics called anti-TNFs or TNF inhibitors. However, there are other things that we do consider when we're deciding on biologics, and that would include risk assessment for infections, other conditions, whether there was any problems with previous medications, and so on and so forth. And so we do know that interleukin-17s are another group of medications that are now available for patients with ankylosing spondylitis, and we'll discuss that a bit further later. And recently, target synthetic DMARDs or like small molecules have been recognized to have potential in controlling ankylosing spondylitis. But I think, at this current moment, cost is still something that's fairly prohibitive for this group of medications.